even in medical school, um, we don't have a chapter of peptides. We have chapters of hormones, endocrine, but peptides is not yet in the mainstream medicine. It's not in the medical curriculum yet. And why? Because it's very difficult to control them. It's easy to make them because they're made from hormones, basically, of your body, and they take pieces of it. Growth hormone, they take piece of it. Melanocyte stimulating hormone, they take piece of it. They make from it KPV. And so it's basically pieces of hormones of your body. And if it's growth peptides, that's mean mainly it will affect the mTOR and stimulate the mTOR. But they're trying to come up with peptides where they have only the good effect that you're looking for without the side effect. Like growth hormone, if you give growth hormone to the patient, yes, it will stimulate the growth, but there's a lot of side effects of it. You end up with metabolic syndrome. And so, but if I can take a piece of growth hormone where I can only stimulate the growth without causing metabolic syndrome, then that is the piece of peptides that I can make, and I can use it as a treatment. Or take a piece of thymosin alpha or beta hormones and turn it into a peptides, thymosin alpha and beta peptides, to stimulate your immune cells. So they are basically hormones, and yes, there's also peptides, endogenous peptides your body produce to regulate the physiological process of your body. So it could be piece of the hormones, or it could be as peptides that your body produce. So we have a lot of endogenous peptides, but we did not have this peptides and endogenous peptides and what kind of peptides we have in our body in medical school. It's not in our curriculum, and that needs to be integrated in our medical schools, knowing all the functions of the peptides, whether the synthetic ones that we are making from the hormones by taking pieces of it, or the endogenous peptides that your body produce, because they work like signaling molecules, and they modulate the effect of the body. Now, it's very important to recognize this is a CME educational category 1 from the American Medical Association. And I think I did send a link in the text if you want to obtain your CME. And it will help to renew your licenses, and also gives you some sort of certificate that helps you to use it, so that when you are practicing peptides, at least you have a certificate that shows that you are aware about the side effects and you have the knowledge about the mechanism of action. And so the CME certificate is something that I will encourage doctors to have it, because it gives them that authenticity to practice peptides therapy. So we did send the link there, and everybody, even if you don't want it, just go ahead and support the room by, it costs you $30. It's less than a dinner, but we will appreciate that, because this will support the whole weekly webinars that we are doing. So let's go ahead and have a peptide that's being synthesized from growth factor. And it also has a potential in treating obesity, and they use for body weight loss. And it's derived, as I said, peptides can be derived from human growth hormones. And they designed to target fat-rich areas. And this peptide is called AOD9604. Is it FDA approved? Not FDA approved. It's still on research and investigations. But you need to have that big pharma to take it and go through all the clinical trials and pay the FDA in order to pass it. It will be good if that's happening, but it seems like it's difficult to contain it, and people can copy it. And the big pharma are looking for something that it's difficult to copy and easy to, contain it. The only way I can see this will, if they patent the technology of delivery, and that's possible, the best way for peptides. And you can use platelets, nanoparticle, and exosomes to load and carry those peptides to the site of pathology and increase its bioavailability and affect its pharmacokinetics, of course. So I do recommend people to get the training to whether loading exosomes or loading platelets nanoparticle, which we provide the training for that, by the way. And doing that, you can even IV those peptides, load inside platelets nanoparticle and exosomes, and you can get them to the pathology versus going everywhere. Um, and so, as I said, if you take the growth factor by itself, it can lead to metabolic syndrome, but they take a piece, and this piece, it seems like it activates or it burns up the fat, and that's what growth hormone does, but without causing hyperglycemia. Because if you give growth hormone itself, you end up with hyperglycemia and metabolic syndrome. And so this peptide, in addition, helps to break down the fat. It's also good for regenerative. So it stimulates the fatty acid oxidation, and that leads to burning the fat, maybe turning the white fat into brown fat. That's possible. But also it helps in regeneration. And most of the time, the peptides, yes, we need to consider those four pillars. Remember, when you manage chronic diseases or you want to know the effect of the drug, is it regenerative? Is it modulating the redox, the metabolism, the immune? In this case, it's very clear it modulate the immune, but modulate the metabolism by increasing the fatty acid oxidation and burning the fat. And also it changed the metabolism by stimulating the mTOR signaling. And so you can see this drug works through the metabolism and regenerative. So it's a regenerative metabolic drug under that category, because we know the four categories that we have. Yes, we have four categories that we know: regenerative, metabolic, immune, redox. And I think this growth hormone works through the regenerative part, stimulating mTOR and stimulating possibly fatty oxidation and burning the fat. And of course, the regenerative part of it could be good, especially for the cartilage. If there's any significant clinical significance, we can say we should, especially for sport injury, that will, and then you load them inside exosomes, yes, and possibly regenerative effect in the synovial fluid, and synovial membrane and synovial cells, and secreting lubrication. And so loading this, and possibly can load those peptides in the exosomes and platelets nanoparticle and inject them into the joints. That's the reason I like everybody here to learn how to load drugs into platelets and exosomes. Anybody who's doing integrative regenerative medicine, loading platelets to drugs in the platelet nanoparticle, it's critical. It's important. Think about it: injecting a peptide into a nakedly, or a drug nakedly, it will be degraded. It will go everywhere. Versus if you wrap it into nanoparticle, you are slowly releasing it, so you're changing the pharmacokinetics, and also you're targeting it to the pathology, to the inflammasomes, senescent cells, and if it's based chemotherapy, you're targeting it to the cancer cells. So I think, that every doctor who's integrative regenerative needs to learn how to load stem cells and exosomes and platelets with drugs. And if you want to identify yourself as regenerative medicine, and you want to do the peptide in a more effective way, because those peptides can be easily degraded when you inject them nakedly, you load inside exosomes, you prevent them from being degraded because you're protecting them, you're clothing them, especially with clotho, right? And I think Dr. Joseph is doing it, and he can take exosomes, load it with clotho, give it IV, and it gets to the kidney, and it helps changing the tissue of the kidney, the ratio between the fibrotic tissue, which is scar, and the parenchyma. And you can monitor that by using ultrasound, and you can see the change from hypoechoic tissue, hyperechoic tissue, which is scar tissue, into hypoechoic tissue. So the mechanism of action works, as I said, it works on the metabolism by stimulating the degradation of the fat, beta fatty acid oxidation, lipolysis. aggravate the beta-adrenergic receptor. Unlike unmodified growth hormones, the growth hormone can lead to metabolic syndrome, can lead to insulin insensitivity, and can resistance, and can lead to diabetic. You don't want that, and you don't want giving growth hormone itself, but pieces of it where it does the good thing without doing, the bad thing. It's same like KPV, which is derived from, it's a 3 amino acids, and valine, proline, and something else. And there's 3 amino acids derived from melanocyte-stimulating hormone. It does the same action for melanocyte-stimulating hormones, which has anti-inflammatory, anti-infectious effect. It makes holes into the fungus and the bacteria, and also those envelope viruses, and it kills them. But it does not cause the stimulation of melanocytes, so it will not cause darkening of the skin. So you see pieces of those hormones, we can extract them to do the good thing we wanted from that hormone without the side effect of it. So what is the recommended dosage? From range 100 microgram to 1000 microgram per day. That's the range. And it's administered through subcutaneous injection, so it's very safe. And exact dosage may vary depending on individual needs. So it's a weight loss. But because of its regenerative effect, I would like this to be given along with Ozempic, because you would have the synergistic effect of breaking down the fat tissue. Ozempic and GLP-1 works by decreasing the appetite. This will work by burning the fat at the same time, stimulate the growth of the muscles, and also the bone because of its growth effect. So this will be a good thing that you can combine it with Ozempic. The question is that, is it FDA approved? But it will be very good if we combine with Ozempic, because you can minimize the side effects of the GLP-1. So it's administered through subcutaneous injection. Exact dosage may vary depending on individual needs and goal. It's essential to consult with healthcare provider, of course. All the time, pharmaceutical drugs needs to be given by the doctors. Because if there's any allergic reaction, anything like that, or expecting the patient will have allergy, then he can supply the patient with those epinephrine pen, and also see if there's any side effects needs to be monitored as well, and any drug interaction. So while this AOD9604 is generally considered safe, some common side effects has been reported. These include mild transient pain at injection site, swelling, possibly increase the heart rate. It's important to note while these side effects are typically mild, any neuroconcerning symptoms should be discussed with a healthcare provider. So it's very important that this has to be monitored by a doctor, as any pharmaceutical drug. And let's go ahead with some cases here for weight management. Patient Mr. Johnson, 45 years old, man with a body mass index of 32, which is above 25. So he's kind of overweight. Chief complaint, Mr. Johnson is struggling with obesity and wants to lose weight. Clinical scenario, Mr. Johnson visited his primary physician seeking guidance for weight management. The physician discussed lifestyle modifications, very important, low carb, exercise, including diet and exercise. As part of the treatment plan, the physician prescribed this AOD9604 at the dosage of 500 microgram per day via subcutaneous injections. Over the next few months, Mr. Johnson experienced gradual weight loss, improved energy level, and reduced appetite. And a regular follow-up monitor is progress and address any side effects. That's what we need to do. And the outcome, Mr. Johnson successfully lose 15 pounds and achieve a healthier BMI. So I would do recommend this to be given along with GLP-1 because this drug would help in the side effects of the muscle wasting and bone wasting from the GLP-1. How long when you use GLP-1? We need to have a lecture for GLP-1, and I'm putting it together, or maybe Dr. Giuseppe Stefano, Dr. Petar will put it together for us. The case 2, cardiac regeneration. So because of its effect as regenerative. And even if we say here it's called regenerative, but mainly it's for sport injury for the youngsters, less than 50, and they damage their cartilage because of the sport. I would recommend. But for osteoarthritis, I think it goes more of regenerative effect of the synovial membrane and increasing the lubrication. So we have 60 years old woman diagnosed with osteoarthritis in her knee. Chief complaint, Mrs. Patel experienced knee pain, stiffness, and limited mobility. And Patel consult orthopedic specialist for the osteoarthritis. Specialists recommend combination of physical therapy, pain management, and also use this therapy. I think you can inject into the joint. 200 microgram directly into the affected knee. Now, in this case, it will be good if you load inside exosomes or platelet nanoparticle. You can have more sustainable release of the drug, more protected, and also targeting the inflammasomes, the senescent cells, and you can get them inside the cells by endocytosis. And instead of being target, when you give them nakedly, the fluid inside the synovial, a lot of enzymes that will break them down, break them up. So protecting it, capsulating them inside platelet nanoparticle, or exosomes, it will be a good idea. Over several months, the notes reduce pain, improve joint function, increase the flexibility, and mainly in this case, it's not really cartilage significant building up, but it's because of decreasing the inflammation in those synovial cells. They've been recovered from the stunning effect of the inflammation. So follow up with imaging reveals sign of cartilage urination, yes, but it's not that significant. Mainly, it's the lubrication. The outcome, Mrs. Patel experienced better quality of life, reduced lines on pain, medication, and improved the knee function. Okay, so let's go ahead with some MCQ. What is the primary clinical application of this AOD9604? Treatment of diabetes, obesity treatment, and bone weight control, body weight control, blood pressure regulation, cholesterol management. I think the answer is very clear. It's for obesity treatment and weight loss. Although it has some regenerative effect, you can use it for pain management as well. How does the AOD 9604 differ from natural growth hormone in mechanism of action? It does not cause metabolic syndrome, right? It does not cause insulin resistance. So it has slower onset of action. It does not regulate the fat metabolism. It does not have adverse effect on the blood sugar or growth. That's exactly what it is. Okay? It does not cause metabolic syndrome that the growth hormone does. What is the typical dose range? We talked about from 100 to 1,000 microgram per day. And which of the following is common side effects? Severe headache, transit pain, at injection site. That was one that we learned. What else? Significant weight gain, no. Hypoglycemia, so the pain at the injection site. In which form? This peptide administered subcutaneously, which is C. We good with this peptide? Okay. It's already available, this peptide. You can search it and find it. But because it's not FDA approved, make sure that you have a document of investigational effect or whatever letter of mercy to use it. The DPC 157 is also a peptide with variety of potential therapeutic effects, particularly in healing various types of tissues. There's an expanded and organized overview of BBC 157, including its immune modulatory effects. That's very important about the BP 157. Its immune modulatory effect, and mainly it inhibits the Th17 inflammation. That's very important part of how the BP 7157 works, BBC 157 works. But also it may have some rabbit wound healing, so it may have some mTOR stimulation effects, some growth effects, or stimulate mTOR. giving you some growth and healing. Um, but also it modulates the immune system, and so it decreases that excessive inflammation that hinders the healing, which is mainly Th17 over activities. And because your gut produces the the BB157, oh, it is in the intestine, by the way. It does help in creating that boundary or the tight junction between the epithelium. So it's good um, for managing leaky gut syndrome. And also it because of its healing effect and helps in stimulating the growth of the gut epithelium and forming the tight junctions. Um, so you can use it to manage leaky gut syndrome, or also you can use it for ulcers, inflammatory bowel syndrome, and other GI tract disorders. What is the origin of BPC157? It is derived from protein found in the human gastric, by the way. That's why it's good for the gut epithelium in general. It stimulates the growth and healing and tight junction, and also it helps it decrease the overactive Th17. Um, and because when you have overactive Th17, then you break up the tight junctions, and you end up with leaky gut syndrome, and also it can lead to ulcers. So it's anti-inflammatory healing effect, especially on the GI gut epithelium, managing leaky gut syndrome and all this inflammatory septic ulcer diseases, or inflammatory bowel disease you can use for ulcerative colitis and inflammatory bowel disease, ulcerative colitis or Crohn's disease. So it's very good for protective and healing properties, especially in gastrointestinal system, but also to extend, and it's good for other part of the body because of this healing effect, stimulating vasodilatory and modulating the immune system and decreasing those inflammatory, uh, uh, excessive inflammatory reactions and balancing the immune system. So here, how it works through mTOR, a regenerative effect, and also it modulates the immune system. So that's when we talked about the pillars of the chronic disease prevention management all the time. Put in your brain the drug's effect, whether, okay, here it's more mTOR regenerative and it's balancing the immune system. So BBT157, the peptide with regenerative properties, has been studied for potential immune modulator effect. And here's the expanded look at the how BBC may interact with different aspects of the immune system. And so if you have too much of Th1 or too much of Th2, it helps to balance it. So it balances the ratio between Th1 and Th2 and restore the balance between them. So that's good. If you have inflammatory bowel disease or you have multiple sclerosis, you may end up helping to balance the immune system. And it have the Th17 for sure, excessive Th17, and that's very important for autoimmune diseases, especially inflammatory bowel disease or multiple sclerosis. And it does polarize the immune system more to Treg. And that gives you this anti-inflammatory effect because Tregs produce interleukin-10 and helps to put all the effector T cells to inhibit them, whether it's Th1 or Th2 and Th17, calm them down. So this is very good drug. It's an anti-inflammatory, and it does stimulate the healing. It stimulates the mTOR. So it's a good peptide for managing um, degenerative diseases and autoimmune diseases. Because it inhibits the Th17, so it has some promising effect in cancer. It does have also effect on the blood vessels. I think it works by restoring the blood vessels integrity, because maybe it has antifibrotic effect, but that's very important because if those blood vessels are being squeezed by fibrosis, then you will decrease infiltration of the lymphocytes. And by its inhibition of Th17, so we can use it for cancer. But again, and when anytime you use, there's a lot of other factors that we don't want it in cancer, like polarization of Tregs. In that case, you need to give this peptide with other things that helps to polarize the immune system to Th1 and help the Tregs, like adding interferon gamma, adding anti-PD-L1, anti-CTL4, adding thymosin alpha with this peptide. Maybe this will help to restore the tumor microenvironment to be a hostile environment for the cancer. But don't use monotherapy. Don't use it alone. Use it with other things. That's my recommendation, because and so you can get the best effect of it that is in favor of cancer, and then things that's not in favor of cancer, you can create the protocols that will antagonize that, so you can get the best of all the drugs that you are giving to the cancer. And cancer needs to be given or treated by multi-therapy, not by monotherapy. And knowing exactly what you're doing. In this case, we are trying to kind of maybe normalizing the blood vessels, and also inhibiting TH17, and then you need to add some drugs that polarize the immune system to monitor TH1 and inhibit the Treg, because we know this drug does stimulate the polarization to Treg. The doses for BPC-157, based on the condition being treated, but typically range from 200 microgram into 800 microgram per day. The side effects, while the side effects are uncommon, some individuals may experience nausea and gastrointestinal discomfort when the BBC 157 is taken orally. But I don't think you will see it with injection, especially with the GI discomfort. So let's go ahead with some clinical cases here. Case 1, accelerating wound healing. Patient, a 45-year-old male with history of diabetes, present with non-healing diabetic foot ulcer. So we need to get the benefit of the BB57 regenerative effect. Treatment: patient administered BBC 557 at dosage of 200 microgram per day by subcutaneous injection near the wound site. Okay, and the outcome after 2 weeks of the treatment, the patient shows significant improvement in the wound closure because it stimulates the mTOR. It decreases the TH17 inflammation that hinders the closing of the wounds and reduce the inflammation. And this healing is accelerating comparing to the standard wound treatment. So something you may consider to treat diabetic ulcers. Another case, gastrointestinal recovery, patient at 37 years old, female with Crohn's disease, experienced a flare-up with abdominal pain and ulcers. Treatment is BBC 157, given order at a dose of 500 microgram per day to promote gastrointestinal healing. The outcome: the patient reports decrease in abdominal pain, improving gastrointestinal function. After 4 weeks, endoscopic examination revealed healing of the intestinal ulcer. So we need that. It decreases inflammation by inhibiting TH17. We know this one stimulate the epithelium growth by mTOR stimulation, and you can see it does help in managing inflammatory bowel disease, whether it's Crohn's or ulcerative colitis. And also it's good for leaky gut syndrome as well. So what is the primary clinical application of BPC 157? Is it blood pressure regulation, wound healing, cholesterol management, sleep disorder? The answer is very clear: wound healing. BPC 157 promote the healing process through neurogenesis, angiogenesis, lipogenesis, or myogenesis. What will be the answer here? Angiogenesis, that's what we learned, that it affects the blood vessels, right? Okay. Which cells might BBC 157 influence for its immunomodulatory effect? Red blood cells, neurons, TH1, TH2, and muscle cells. TH1, TH2, it helps to balance it. So if you have too much of excess of TH1, it inhibits it and polarizes it back to TH1. So it's balancing the immune system. What is the potential side effects of BBC 157 when taken orally? I think it's more of the GI problem, right? And we can say nausea, right? The typical dosage range for BBC 157 that we learn, it's around 200 to 800 micrograms per day.
Dr. Halasa,
Yes.
do you have an opinion as to whether BPC 157 works better orally or subcutaneously, or does it depend on the condition?
Yeah, depending on condition. If you have GI gastric problems, I would use it orally just to get it locally there. If you have multiple sclerosis and other system, I would do subcutaneous injections.
Thank you.
So yeah, or maybe you do combine both and getting the effect of both, right? Um,
I could speak from experience to
right.
this one. Definitely subcutaneously works better for the musculoskeletal injuries, especially the anti-inflammatory qualities, the pain relief, and the healing speeds up. It definitely works. Orally, it doesn't seem to be so potent when it comes to musculoskeletal injury, but I do prescribe it in combination with KPV in a capsule form for especially for patients with mast cell activation syndrome, in combination with ketotifen, actually, which is a very potent mast cell stabilizer. People with gut issues, heavy metal toxicity, uh, like you said, directly working on the gut wall, and so that's basically been my experience.
I agree with you 100%. I think when it comes to peptic ulcer and all that stuff, you want to give it orally, but when it comes into systemic, you want to do subcutaneous. And now, if you load them inside exosomes and play the nanoparticle, even doing it subcutaneous, you can get better result because you're packing them and you are protecting them from being degraded, and you're causing them to be targeted to the pathology or the inflammasome and senescent cells. So I do
And I,
recommend it.
yeah, and I do have experience with loading them into nanoparticles. Uh, Even treating, my mother can speak to this. The first time we did it in combination with thymosin beta and methylene blue, and gave it IV and also put it into a nasal spray form, her eyesight and her smell improved pretty dramatically.
Yes.
And I've injected BPC 157 into knees, loaded in the platelet nanoparticles many times. And so BPC 157, I haven't had any issues. No, I only had one side effect with a patient who did it subcutaneously for gut issues, and she became almost like bloated, like constipated. But you know, what I tried to figure out was why. And what I do know is that BPC 157, it actually works really good for diarrhea. And so I reasoned that it probably controls the gut motility to a certain degree. And if you take a large dose, if somebody's prone to having really reactive gut issues or getting distended really easy. But that was just one situation. And I did come across this sort of concept that if somebody has a really sensitive gut and they're dealing, say, with heavy metal toxicity, that they can start with the thymosin alpha for a week, and that sort of reduces the inflammation really well, actually. Thymosin alpha reduces pulmonary inflammation, gut inflammation really powerfully, and then started the BPC 157. So that was the only issue. I was surprised I would have any issues because typically peptides, in my experience, do not give any side effects. And they're nice because even when you stop them, it's almost like they're still working because of the fact that they're modulating genetic expression. And then one other thing, AOD was my absolute favorite weight loss go-to peptide until it kind of got taken away and it popped up somewhere else. And so now that it's available, I would highly consider it to be something to add to somebody's weight loss program, especially if they're trying to get off of, they got the results from the semaglutide and they're weaning themselves off. I think AOD would be a great one to transition to, or just by itself, AOD. But it's an injectable form is what I found it to be very powerful, within 20 days, I saw noticeable results with my patients and myself. It works without any side effects. I mean, it doesn't affect that hunger, any of that stuff. It literally just burns the fat. That's my understanding of it. No side effects whatsoever. So I can speak from experience with all of these peptides so far.
Yeah, I agree with you 100%. I think if we combine both of them, we may get better results in minimizing the side effects of the Ozempic's weight, muscle wasting and bone atrophy, using those two together and lower the dose of each one of them. And so you can, when you lower the dose, you decrease the side effects, basically.
Yeah, absolutely. And you have to be cognizant that there are patients that are sensitive, ultra sensitive to anything. And that's what I learned, as they cannot tolerate big farm drugs hardly at all. And even with peptides, they need to go with a very minimal dose. Like maybe if the BPC 157, the average dose, say, is 20 units in it from a BD syringe, that they can start at 5 units. Now, this is a smaller percentage of the population, but what I've learned is that there are people out there that are super sensitive to everything, and the things that should work may give the opposite effect, side effects that don't make any sense. And these are typically people that are prone to heavy metal toxicities and parasites, and they've got Lyme, they've got detoxification issues, or issues with, or difficulty breaking down histamine. And so just remember, there are patients out there that if they are sensitive, if you ask them, are you the kind of person, if you're going to have a side effect, if there's a side effect to anything, this is what I ask people. If there is like one person who would have the one side effect that nobody else would have, would that be you? And they laugh it and they go, oh yeah, that's me. Then know that you can start any peptide at its absolute lowest dose, and then they can see how they do. That way you don't run into the situation of treating them like everybody else, putting them on the same dose, and then all of a sudden they're the one that has the side effect that you cannot explain.
Yeah, I agree with you 100% there. And also, we don't know exactly if there's any impurity, so make sure that the source of where you're getting the peptides are clean and almost 99%. And the more certificates you have on those peptides, the better.
Yeah.
So thymosin alpha 1, which is originate from thymosin alpha protein or peptide, and they're a short fragment of the longer precursor of thymosin, and it helps in, this is more or less of enhancing the immune system, stimulate the lymphocytes, all of them. So it increases the lymphocytes population. It's stimulate the growth of the lymphocytes population and replications and expanding of the lymphocyte population, regarding of the type of it. But specifically, it polarized the immune system more to Th1. So this is good for cancer. But again, it stimulates the lymphocytes in general, and it does inhibit more of Th17. So polarized Th1 have the Th17, but because it increased the whole thing, so you may get also Tregs increased as well. But I will recommend this for cancer and for viral infection, because it does, yes, it increases the lymphocyte in general, all type of them, but a more polarization to Th1. And so this is good for cancer, for cells that's being infected with viruses, viral infected cells, cancer. I would use thymosin alpha. Epstein-Barr virus, infection, herpes simplex, HIV, cancers, COVID, this will be a good drug, because that's where the missing part of the immune system is, polarizing immune system to Th1.
Can I add something too?
One question I have, what is the best source or what are the companies? Can we ask that on the
We
CME?
cannot talk about the companies now, because it's CME, but after the CME, feel free to call me and I can recommend your companies. Is that okay?
Yes.
I do want to make a comment as well, when it comes to Th1 versus Th2 dominant autoimmune diseases, because there's been this debate early on as to how to treat, like, say, somebody with rheumatoid arthritis, considering that technically is a Th1 dominant autoimmune disease. And so I was concerned whether thymosin alpha would worsen or it would help. And I can say from experience that it's okay to do thymosin alpha with Th1 dominant autoimmune diseases, and because they all seem to have a positive effect. Even asthma has improved dramatically with.
Yes, asthma, yes, because asthma, you have Th2 dominancy and you want to balance it back to Th1.
Well, that's
But
true.
rheumatoid arthritis,
Well,
it depends.
Yeah, but here's what I'm saying. From experience, thymosin alpha works with rheumatoid arthritis. I mean, perhaps alternate with thymosin beta, but I think it's because thymosin alpha, like probably part of the issue might be that there's chronic underlying infection that, by increasing the immune response is helping the condition. But I believe that thymosin alpha intrinsically, the peptide itself is anti-inflammatory. You see what I mean? And that it's not producing such a dramatic shift in from Th1 to Th1. I don't think it's. I like the line of thinking, but in my experience, thymosin alpha works very well for practically any autoimmune disease, regardless of whether it's Th1 or Th2 dominant. And that's just from my experience.
Let me emphasize something there, because those autoimmune diseases from rheumatoid arthritis, it's not just Th1 dominant, it's also Th17 dominancy. And then thymosin alpha doesn't have it, the Th17. Yes, it favors the Th1, but it doesn't have a Th17, and it does increase the T cells in general, including Tregs, by the way. And maybe those autoimmune rheumatoid arthritis that you have, they are more of Th17 dominancy more than Th1 dominancy, and that's why you get some good result out of it. I mean, most of the rheumatoid arthritis Th1, Th17, but if there's more of Th17 than Th1, then you'll experience that the thymosin alpha did help. But my recommendation is just go ahead, give thymosin beta, and I'm okay to give thymosin alpha, but you need to give thymosin beta at the same time, so that you make sure that it will not cause that leap of Th1. But just inhibit Th17.
Yeah, and I've seen that before, and that would actually be a great idea. I think I haven't done it recently because the thymosin beta wasn't available. But what I can say is I haven't had any adverse reactions or worsening of inflammation with the thymosin alpha. But I agree. And the other thing is, unless you're getting a lymphocyte map, we really don't know, because there's multiple things going on with patients. And what I found is that the lymphocyte maps that, diseases that should be Th1 dominant don't always show up as Th1 dominant on the map, because there's multiple things. There's usually more than one thing going on. And although there is correlation in actual practice, the lymphocyte maps do not correlate 100% with what you would think, what you would expect with certain diseases that are supposedly Th1 dominant. You know what I mean? Because like I said, there could be something else going on that's shifting it towards Th2, so it's sort of balanced out. But definitely from my experience, I have not had any worsening of a condition when giving thymosin alpha. And I just say that because, I toiled with this issue for quite some time.
I have a question, Dr. Joseph.
Yes.
Now, we know that when we age, the thymosin volutes. So when you give the thymosin, does it revive the thymus or what happens?
Yeah, that's a great question. And in fact, I was I'm trying to refer back to an article that I reviewed on it. And what we do know is that the thymosin alpha is released by the thymosin cells at maturing the T cells as they are passing through. That's my understanding. As far as increasing the size of the thymus or regenerating the thymus, I don't remember that thymosin alpha is doing that. I think what we're doing really is we are compensating for the suboptimal performance of the thymus, or the atrophied thymus is not able to mature the T cells as well. So thymosin alpha is acting more in the role of optimizing the T cells for a suboptimal thymus. That's
Well, you know, basically the lymphocytes is not produced only from thymus, it's produced by the bone marrow. That's actually the source of most of the lymphocytes. And you have the choice of becoming white blood cells or lymphocytes. So this thymosin alpha and beta both stimulate the polarization of your white blood cells line, the stem cells, the hematopoietic stem cells, to produce more of the lymphocytes. So it's kind of lymphocytes progenitor, and it helps the stimulation there. And then they have some favor, a little bit favor, thymosin alpha favor Th1, but both inhibit the Th17, doesn't go. What the thymosin beta favor the Th2, but they're all increasing the the polarization of the blood cells line into more of lymphocyte versus granulocytes. Does that make sense?
Yeah, I wanted to comment on the thymus gland atrophy issue. I think we need to ask ourselves why is it atrophied? Instead of just saying, well, that just happens when we get older, is there an underlying chronic infection? Is this the result of
You mean
other?
physiologically, those thymosin tissue are not that much of function anymore? Because their rule in the beginning is to get rid from any auto uh, immune cells.
Yeah.
That's their position in the
Well,
beginning, and maturation of the lymphocytes. And
the question I was saying is,
Yeah.
why is the thymus gland
Yeah.
shrinking to begin with? Is there underlying, and I'll just throw this out there, is there underlying Epstein-Barr virus infection involved? Or, Dr. Patel had mentioned a lot of thyroiditis comes from the herpes type 6 infection. So it makes me wonder if there's underlying chronic infectious disease that leads to the thymus gland to atrophy like that, other than just, oh, it's the person is older. And I'm just saying that's something perhaps to think about. Why is it atrophying? But as far as I know, thymosin alpha does not regenerate the thymus gland itself or cause it to grow, back to its original size.
no, they work on the bone marrow and increasing the polarization of your hematopoietic cells to produce more lymphocytes versus neutrophil and basophil and other lines of blood.
So in this particular case, the effect is not on the thymus, it's rather it's used in other areas of the body, like the bone marrow, for selection of the T cells.
Yes, yes, the polarization and moving it to produce lymphocytes, and that's very critical when you're trying to kill cancer affected virus. You have to have enough of lymphocytes, especially the Th1 lymphocytes and cytotoxic T cells. So
Now,
I do recommend thymosin alpha for Epstein-Barr virus and Lyme disease, and possibly many intrapathological intracellular pathogens along with cancers.
well, I mean, look, now I've got an article here that states specifically that thymosin alpha is a peptide hormone that is endogenously produced by the thymus gland.
Right.
And
Right.
Okay, so I've come across several citations that the thymus gland is also producing thymosin alpha.
Correct.
Yes, but the effect of it, not necessarily on the thymus, and the effect of it is it's on the bone marrows.
Well, okay, well, I mean, here it's stating it potentiates the T cell mediated immune responses via differentiation and maturation of T cell progenitor
Right.
cells,
Yeah.
activation of dendritic, because I thought that was where the T cells, it's like, you know, if they're strong and healthy, then they will get
Yeah.
selectively matured,
That's the selection. Yeah, that's the selection place. So
right?
Yeah,
And
right.
if they're not, if they don't make the cut, then they don't get matured. They get, I think, destroyed.
Or you don't produce enough of it, they would move to producing other form of white blood cells or red blood cells. You need to have some degree of moving it to lymphocytes. So this helps to move the stem cells of the blood cells into polarized, become lymphocytes instead of neutrophil and basophil and all
Okay,
that.
so maybe a combination of both. It's also it's produced by the thymus gland, the maturing T cells that they pass through, but it's also involved with the bone marrow selection. Is
Right.
that safe?
Yes.
so in a way, maybe even though the thymus gets smaller, it's not dead. So when you boost it up with the thymosin, it does help the selection process somehow still.
Right. Okay, somebody is talking in the screen. Can you go ahead and help me up here? Because I cannot do both. Can people who have the co-admin? So anyway, so the thymosin alpha, we know
Dr.
it does.
Halasa, can I, it's
Yes,
Dr.
go ahead.
Patlar, just 1 minute. Thymus atrophy, we have seen in pediatric patients when they have a lot of infections or they have a problem with the deficiency in the immunoglobulins, or they are deficient, I mean, T cell deficiency problem or T cell dysfunction. So and usually by the adolescents, you don't see much of the thymus. So when we are talking about the aging and the elderly patients, we don't have much thymus to go, the white cell to go and become T cells. So, and that may be a primary reason why, as one ages, there's the increased incidence of cancer, besides the epigenetic phenomena, etc., etc. But I'm talking from the immune function viewpoint. So I think giving the patients TA1, and there are hundreds of articles, they say that even with chemotherapy, they give TA1, immunotherapy, they give TA1, the outcome improves. So this is some information that I thought is important.
Yeah, so what would be the mechanism of action though? So that's the major thing. So what is the when we give the
Well, to
medication,
increase the
how
lymphocyte in general, which is the production from the blood cells, and instead of moving and producing granular sites, which is neutrophil, you have something that's pushing them to become lymphocytes. So you need to have those growth factors that moves things to the lymphocytes. And then after that, it does help to it just prefer moving to Th1. In other words, cytotoxic T cells, which is very important for killing cancer and those cells that's been infected with pathogens. That's why we recommend it for a patient with hepatitis. They did very good with it. HIV, they did very good, and also with a patient with COVID, and also cancers, because it does help to boost the Th1 and cytotoxic T cells. So lymphocytes in general, but specifically the Th1.
And I was
does
gonna,
it do anything for NK cells, the natural killer cells?
But yes, natural killer cells is part of the cytotoxic T lymphocytes. It's just non-specific in the form of it. Well, cytotoxic T cells is more specific. But yes, it worked with natural killer cells.
I was going to say, I see a few citations here talking about human growth hormone and insulin-like growth factor may influence thymus gland size and improve function of the thymus cells. So, there may be something we can do about the thymus size through the growth hormone or growth hormone releasing peptide or insulin-like growth factor. I haven't read those articles, but I just wanted to say at least it's mentioned.
Yeah, it's
Right.
making my wheels turn because when I think about that, I say, wow. So if we can somehow make the thymus more potent or do things, perhaps we can do much better immunologically.
Yeah, no, I agree, Dr. Tano. And I'm curious too if stem cell therapy also can sort of strengthen the thymus gland. Because again, what makes me curious is why is it atrophying? Okay,
Right.
besides just getting older, is there something? Do some people atrophy more than others? And again, those are just questions that I think about.
Right. So if you see here, as I said, it does favor the Th1, and it does boost it, especially, which will help us a lot in managing cancer and intracellular pathogens, which is hepatitis B, C, COVID, herpes, zoster, Epstein-Barr virus. So it does enhance the cytotoxic T cells and Th1 and natural killer cells by stimulating interferon gamma interleukin 2, which will help the macrophages definitely to polarize to M1. And they are very essential for defense against viral and cancer, especially the intracellular bacterial infection. While the Th1, mainly it inhibits the Th1. Yeah, as I said, it stimulates the whole thing, but it does, when it's excessive, like an allergy, it does inhibit the Th2, and it balances the Th1 and Th2 for the allergic people with allergy. So it's good for people treating asthma. You can use thymosin alpha for treating asthma and for any excessive allergic reactions to the parasites, because it does balance and push and shift the Th2, Th1. Th17 cells doesn't have the Th17 cells, by the way, and so that's why maybe you see good results of giving thymosin alpha for rheumatoid arthritis, maybe because of its inhibition against Th17 population.
Does this actually interfere or work with the thymic stromal lymphopoietic cells?
What?
Does the thymosin, this thymosin work with TSLP?
THLP?
No, TSLP is called. It's of the thymic stromal lymphopoietic cells, epithelial cells that do provide some everywhere in the skin, the gut, the lungs, the thymus.
Yes.
So if it does affect that, then perhaps that is probably one of the pathways through which all the cells are reinforced.
Right. It doesn't increase the secretion of the growth factors that leads to polarization of your blood cells into lymphocytes. So generally it increases the lymphocytes population, but especially the Th1. Again, it does increase the Th, all of them, including Tregs. And so I think it's a good drug for use it against cancer infection. In summary, the thymosin alpha acts as immune regulatory that modulate the activities of various T cells and enhancing the body immune response against the pathogen, especially virus, and so it's balanced the immune system. And most of what we have, and whether it's toxic or environmental or infection, like COVID, they all move the immune system away from Th1. That's the problem, and that put us at risk of cancer. Like COVID, it polarized the immune system Th17 and Th2, and that caused imbalance in the immune system and decreased the cancer surveillance and put us at risk of cancer. So a lot of toxins, cortisone, for example, also they favor the immune system to move to Th17 and Th2 and suppress more cytotoxic T cells. So stress can interfere with the immune surveillance. And bacteria infections, chronic infection, especially the bacteria, it does polarize the immune system to Th17, and that compromised immune system puts us at risk of cancer as well. And so knowing that, we really need thymosin alpha, because even mycotoxins, fungus also polarize the immune system away from Th1. And so knowing that all this environmental toxins, estrogen dominant syndrome also compromise the cytotoxic T cells and move things more into Th2 and Th17. I think we need to consider giving thymosin alpha to empower your immune system against intracellular pathogens and cancer cells.
Did you get any results with COVID, long COVID syndrome, or any of that?
Yes, there is good results that's being published already. We did recommend a lot doing thymosin alpha. I think Dr. Joseph and Patel, they're using it for a patient with COVID and also for post-COVID. And Dr. Patel is using it a lot for cancer. Again, when you use it for cancer, I think it's good to add the CTL4 antibodies and anti-PD-L1, along with other peptides that helps to regulate the blood vessels as well, making sure, and anti-fibrotic drugs as well. You need to give this cocktail for cancer. One way it's not going to be enough. So hepatitis B, C, all this intracellular pathogens will be good. HIV, that's a good thing. Cancers, right? Malignant melanoma. And chronic inflammatory condition, especially if it's Th2 and Th17 dominancy, I think it's a good thing to give them thymosin alpha. Allergy, for example, that'll be good. Lyme disease, so you can enhance the killing of those infected cells with Lyme, and you get rid from the Lyme and the cells that's being infected with. Getting rid from inflammasomes, senescent cells, maybe, with empowering thymosin alpha. Mechanism of function, thymosin alpha interact with the immune system, regulate the production of cytokines, basically all cytokines, but specifically the interferon gamma interleukin 2, which will help in polarization of the lymphocytes in general, but specifically the cytotoxic T cells, and also the natural killer cells, because natural killer cells is cytotoxic T cells, but it's non-specific, but they are the same. They work with any pathogens, not specific.
Halasa, that patient with the COVID autoimmune encephalopathy, did he try TA1 to help him on whether a TA1 works for that or not? Because we see a lot of patient in different degree of encephalitis and memory loss, cognitive dysfunction. So do you think that the TA1 helps after maybe 12 months, 15 months?
Yeah, if you have the bug, then you want to get the bug, you get rid from those infected cells, then I will do the Th1, but then I will also, if it's more of inflammation, especially Th1 over activities, then I will use thymosin alpha. I can alternate thymosin alpha and beta because of that. I can start with thymosin alpha to kill the bugs, and maybe too much of inflammation, I may need to move it back to Th2 by giving thymosin beta. So sometimes it's a combination of both. What is that?
How often would you give TA1, and when would you give, TB4 or thymosin beta?
I will do alternate weekly, maybe, for this weekly thymosin
1 week
alpha.
of TA1 and 1 week of TB4?
Yes. I know Dr. William Bill was doing monthly. He alternate monthly. And he does 1 month thymosin alpha, 1 month thymosin beta. I will do also weekly in case, and just change it to buffer the immune system and enhance the Th1 to kill the bacteria. And then if it's too much inflammation, and you have too much of TH1, then I will just go back and give thymosin beta. Maybe that will be along with BBC 157 for the healing part of it, the mTOR effect of it. Yeah.
No, I do want
I'm
to.
not really, Dr. Jeffrey, 1 second. I'm not really familiar with thymosin alpha, but does it have an effect on T regulatory cells? Does anybody know if it has
Yeah,
an
it
effect
does
on?
increase the whole lymphocyte subdivisions, but it favors the TH1. You got my point?
Yeah, because if it does affect the T regulatory cells, that would be great.
Yes, it does increase
So then
all,
it
but
would
it
help
favors the
with
TH1.
allergic diseases and all of that.
Right. So it does increase all, but what I would do if I have allergies, then yes, I will give thymosin alpha because you have too much of TH2. That's for sure. I give allergies.
Yeah, but Dr.
Um,
Halasa, you did say earlier though that it polarizes TH17 to Tregs. So
Right. Okay.
It
Good.
does inhibit the TH17. Yes.
That's
yeah.
good.
And I was going to add something, and this is maybe a plug for a lecture I want to give in the next few weeks, is approaching this sort of chronic brain fog issue and these neurodegenerative diseases, also focusing
We
on
don't hear you anymore.
modulating the nicotinic acetylcholine receptors. I think that's a whole world that we can open up.
I don't hear you.
You can't hear me?
Can you hear me, guys?
Yeah.
Yeah. So what I'm finding
go
is
ahead.
the nicotinic acetylcholine receptors are a place that we can also treat neurodegenerative or encephalopathies or post-COVID issues. There seems to be a lot of really good literature and support showing how that can help with specifically with memory, maybe even tinnitus. It's helping with Parkinson's or reducing apoptosis in Parkinson's. It's helping the modulate the microglia and causing the microglia to uptake and eat up some of the amyloid plaques. But that's something I want to lecture on in maybe in the next few weeks, because I think that's a big, huge piece of the puzzle that we could also look into when it comes to neurodegenerative disease and post-COVID brain fog issues.
Yeah, if you're going to do that, do the muscarinic receptors as well and see and compare and contrast.
Yeah, I mean, and then that's where we can combine things with, it's not just one thing, but we can do the peptides, the thymosin alphas, the thymosin betas. But if we have a strategy for addressing and modulating the nicotinic acetylcholine receptors, that's a whole nother, I'm telling you, that's a whole nother world that we could explore that may be more powerful than we ever thought.
Right, but you have to start thinking that why those receptors and the pathway is affected to start with.
Well, my understanding is that it may be caused by the spike protein. The part that is the bungaro toxin is a nicotinic acetylcholine receptor antagonist. Okay, and it explains so much of the issues.
Not only that, but the most prevalent is the organophosphates, and
What's
there's a lot of research has been done for that, and that affects the brain and all the nicotinic acetylcholine pathways. It is also it has effect on the cerebellum, different layers of cerebellum, and the great research has been done at Duke by Dr. Abadonia.
Yeah,
And
And
that's
so-
why I said to do the muscarinic receptors, because when you have the organophosphates, the way they affect most stuff, they go through the muscarinic receptor 3, and then they have a cascade, and then it increases your insulin level. So, and it does affect the mast cells. So then you have a lot of allergic diseases, brain problems, all kinds of things that go along with it.
And are they affecting the nicotinic cholinergic?
Yes.
yes, you go
Yes.
and look for the workup of Dr. Abadonia. You will
Yes.
find that. he's from Duke, and he did it for a long time ago. And he has done the basic research on that because the organophosphates has become such a problem now. It is one of the main commonly used pesticides. And so, I mean, every human being, including the children in the primary schools, they all have large amount of these organophosphate pesticide residues and the byproducts. But when they are on organic food, the amount was reduced and papers are published regarding that. So yes, we can work on that pathway, but you have to look at the causation. And then the causation, you have to detox before you do repair the pathways or improve the pathways and do the necessary things, because you may do it, it may not be effective. That doesn't mean that it doesn't work. It just, you need to remove the causation, then it will work better.
Yeah, no, I totally agree with that thinking, Dr. Patel. And is there evidence that these organophosphates and maybe the heavy metals are downregulating or antagonizing the nicotinic acetylcholine receptors? Or maybe just downregulating the receptors?
I think once you read the pathology, then you will understand, because it takes a whole lecture to do that. But I'm just bringing this out, so our curiosity will lead us to read, and it's in our volumes. So
Yeah, I'm getting.
sometime we can discuss that. But I'm
I
just
have done a
bringing.
lot of work in that area in terms of, I didn't look at the nicotinic receptors, but I did look at the muscarinic receptor 3 and the pathway through which the organophosphates affect the whole body. All the chronic diseases that you see around, the organophosphate have a hand in it. So even if you take the organochlorines, they also have some other pathways through which they go and affect the chronic diseases. So very, very interesting. If you're really interested in doing this, you may have to compare both the nicotinic and the muscarinic receptors. Now, they already have been done, some of them.
Yeah, and
Organochlorine, it's even the worst. But a lot of research has been done on organophosphates.
Yes.
So that's why I just brought that out. But the
Right.
organochlorine is another animal. It's very, very toxic.
yeah, and I'm coming to the realization that is probably the biggest thing for the brain is this accumulation of toxins. I was thinking more in terms of heavy metals, but now thinking in terms of organophosphates. But the point being that we have to develop specific strategies to help to, I guess, chelate. And I do want to say, I did find out that iodine, by the way, actually chelates mercury and aluminum, just FYI. So there are some things that we're doing already that are helping to bind those heavy metals, but I really do believe that they're accumulating in the brain, and that's leading to, it gets to a certain point, and that's what may be actually leading to the neurodegenerative cascade, I guess you could say. It may be the initial thing that's building up throughout our lives as we don't realize that we're filling up with heavy metals. I see that as the biggest problem now.
Also the effect of insulin resistance on the brain. That is one other big aspect, because of your organophosphates, they end up increasing your insulin tremendously. That's why people who are exposed to it, they get diabetes. So then if insulin resistance causes brain problems, then you can see all the pathways through which all the toxins are affecting the brain.
Right. So the dosage that we're gonna give is 1.5 milligram every 3 days for viral infection, 2 weeks. For HIV, you can go up to 3 months and longer, and you can go even 6 to 12 months for HIV, and for cancer. In subcutaneous injection, thymosin alpha generally well tolerated even in patient with liver or renal disease. That's a good news. Rare adverse reaction include erythema, muscle atrophy, transit elevation of alanine transferase, and causes during pregnancy, nursing, and avoid debilitating immune suppression. Clinical cases, chronic hepatitis B management, patient 45-year-old male with chronic hepatitis B infection. Clinical scenario, the patient present with elevated liver enzymes, fatigue, mild jaundice. He has been on antiviral therapy, but continued to experience flares. Treatment approach, we can start with thymosin alpha therapy at doses of 1.5 milligrams subcutaneous every third day, and monitor the liver function test and viral load will assess the improvement in symptoms and reduction in viral implications. And the outcome after 3 months of thymosin alpha treatment, the patient liver enzymes stabilize, fatigue decrease, and viral load decrease significantly. This indicates that this drug or this thymosin alpha does polarize the immune system Th1 and cytotoxic T cells, and it kills all those infected cells. With the, it kills the virus within the infected cells because of it. Those cytotoxic T cells will attack those infected cells and induce apoptosis and kill the virus within that infected cells. Adjuvant therapy we can use for also cancer, especially non-small cell lung cancer. Patients, example, we have a patient at 60-year-old female with stage 3 non-small cell lung cancer, undergo chemotherapy. Clinical scenario, despite the chemotherapy, the patient experienced fatigue, weight loss, and reduced immune function. I think the best way to boost the immune system is giving thymosin alpha and polarizing the immune system into Th1 cytotoxic T cells to help to kill the cancer. Add thymosin alpha to the treatment regimen, dosage 1.6 milligrams subcutaneously twice a week, and monitor the tumor response, immune parameters, and adverse effects. The outcome, the patient immune response improves, and it can tolerate the chemotherapy. So it's an adjuvant. It's very good. We know the chemotherapy that suppresses the immune system. So having thymosin alpha alongside with that would help to kind of navigate the side effects of chemotherapy suppressing the immune system. And you can see the tumor is regressing. The other application is HIV and AIDS immune modulation. Patient, 30 years old male with newly diagnosed HIV infection. Clinical scenario: the CD4 count is must be less than 200, and the patient experienced recurrent infection. Treatment approach: yes, in those HIV, they have problem with their lymphocytes, especially the CD4 positive. Well, a Th1, a Th2, and Th17, they all CD4, right? Including Th1. Yeah, cytotoxic T cells CD8, but the Th1, if it's being compromised or decreased, then you cannot stimulate the cytotoxic T cells. So you need the CD4 to go up. And I think thymosin alpha would help to increase the lymphocytes population in general, all the CD4s, including the cytotoxic T cells. And the dosage that we recommend is 1.5 milligrams subcutaneously every third day. Monitor the CD4 count, viral load, and opportunistic infection. Outcome of the case was CD4 count decreased, the patient immune system become more robust, and opportunistic infection decreased. So it's I think it's a good thing to have the thymosin alpha as a tool with treating cancer. Autoimmune diseases, lupus, if it's especially polarized immune system like lupus, it's more Th2 dominancy, by the way. So it's a good thing. Allergy, also allergic reactions, Th2 dominancy, and Th17. So pushing it to the Th1, that would be good. Patient, a 20-year-old female with systemic lupus erythematosus. Clinical scenario: the patient experienced joint pain, skin rash, and fatigue. Because we know lupus is more Th17, Th2. Treatment approach: combine thymosin alpha with standard immune suppression therapy, monitor disease activity in autoantibodies and quality of life. And the outcome is thymosin alpha help to regulate the immune response, right? Help to shift the immune system from Th1, Th17 to cytotoxic T cells. So it's balanced. It included Tregs, yes, in this case, and inhibited Th17. So I think we are doing good with thymosin alpha for this case. And it reduced the flare-up and improved the overall well-being. So let's go ahead with some questions, multiple choice. Thymosin alpha 1, origin and structure. What is the origin of thymosin alpha 1? It is a synthetic peptide. It's derived from the thymosin alpha. That's what is the right answer, right? And so that's the right answer is B. Clinical application of thymosin alpha. Which of the following is not a clinical application of thymosin alpha? Chronic hepatitis B and C, yes. Non-small cell lung cancer, yes. Type 1 diabetes mellitus, no. HIV and AIDS, yes. Okay, so the wrong one is C. Dosage and administration. What is the general dosage of thymosin alpha for viral infection? 1.5 milligram daily. We'd like to do it every third day. 1.5 milligram every 3 days is the right answer. And then mechanism of action of thymosin alpha. How does thymosin alpha modulate the immune system? It enhances the whole T cells activities, right? But it's specifically the Th1. So it stimulates the cytokine production and T cell maturation. I think that's the right answer, right? B.
Does it work in all cancers, Dr. Halasa, or is it better for certain cancers than others?
I think it's good for all cancer because here you are modulating your immune system into Th1. All the cancer inside of T cells, all the cancer, they have a problem with that because they secrete chemicals, the cancer itself, to polarize the immune system away from Th1 cytotoxic T cells into T2, Th2, Treg, and Th17. So thymosin alpha will be the good thing to do, along with some interferon gamma if you want, and some anti-CTLA, anti-PDL1
So can
antibody.
it be an adjuvant to chemo for people who do chemo or not?
Yes, of course. This is what we learned today, that we added as an adjuvant for chemotherapy. Again, chemotherapy loaded inside platelets nanoparticle is the idea, especially if you add the platelets nanoparticle. You're loaded with thymosin alpha, you're loaded with thymosin with interferon gamma, you're loaded with your chemotherapy drug 10%, 20% off the recommended dosage, because when you do platelet nanoparticles, you need less dose. You don't need the 100%. You can use 20, 10%, which minimizes side effects. And then loading a cyclic nanoparticle will take these medications mainly into the cancer cells versus going to the healthy tissue versus to compromise the immune system. So I think loading drugs inside platelets and exosomes,
So
it's
people who
critical and
do
important.
cancer immunotherapy
Mhm.
by stimulating the T cells, can they, I mean, have they looked into this? Have they using it? Because I'm not
Yes, they are using it, but what they are happy right now with anti-PDL1 antibody, anti-CTLA4 antibodies, which I like it, but when you inject it freely into the body, that's what the mainstream medicine oncologist does. It does help the cancer, but at the same time, it induces autoimmune diseases, and it trigger autoimmune diseases, and it affect other immune, which will drain the immune system. That's the reason us doing better than the the oncologist or the immune oncologist, because we are loading their antibodies inside platelets nanoparticle, and we're trying to say we are giving it to targeting into the cancer instead of going anywhere, everywhere, which will minimize the side effects of inducing autoimmune diseases. You got my point?
Yep.
So that's the difference that we are doing versus that's the difference between integrative oncology and the mainstream immune oncologist. Or we can call them integrative immune oncology, because I'm in favor of using those antibodies. But load them inside platelet nanoparticle and exosome so that you can minimize the effect on the healthy tissue as much as you can. Thymosin beta also does the same thing, stimulate the thymosin line of the homeopoietic blood cell lines. Yes, it moves it into the production of all of those subtypes, but it favors mainly Th2. And Tregs. So good. This is good for autoimmune diseases like patient with Crohn's disease, with multiple sclerosis. I'll definitely recommend thymosin beta. Or degenerative diseases that's mainly Th17 and Th1, like Parkinson disease. I will use thymosin because degenerative disease also have some immune imbalance as well. So thymosin beta is a multifunctional peptide generated attention for its diverse biological activities and potential clinical application. And here's why you need to know. I will not give thymosin beta for patient with asthma, right? because you don't want to polarize the immune system to Th2. You want to polarize it away. So don't give it to patient with asthma or allergy. Origin, the structure, thymosin beta is a small endogenous peptide originated from thymosin gland. It comprised 43 amino acids, and it belonged to thymosin family of the lymphocyte growth factor. Although the initial association with thymosin beta 4, is found in various tissue, including spleen and peritoneal macrophages. Biological function, what it does maybe stimulate the mTOR, right? And also it polarizes the immune system to Treg, which helps to kind of, if there's any chronic inflammation that hinder the healing, it helps to balance the inflammation and increase the Tregs. But also it may have some stimulation for the mTOR, and also its job in angiogenesis as well, formation of new blood vessels, which is very important for tissue regeneration. So it upregulates the vascular endothelial growth factors, right? And that aiding in damaging tissue repair. So that's good for, also good for diabetic neuropathy, right? Especially diabetic neuropathy where you have shrinking in the blood vessels, right? Atrophy there. In the feet, diabetic ulcers. So that's a good thing. Anti-inflammatory properties, yes, it does increase the lymphocytes, especially Tregs, and polarize the immune system to Th2. So that's a good thing. It inhibit the release of cytokines like tumor necrotic factor, which favor the Th1, by the way, and reducing the inflammation, especially the Th17. Yes, it does inhibit the Th17, by the way. Cell survival by binding G-actin, TB4 also move the cells to right location. So it's good for T regeneration. It stimulates the stem cells, possibly by stimulating the mTOR. It inhibits the Th17, which means it's good because we know Th17 is behind the scar tissue. So it decreases the number of cells between muscle fibers, minimizing the scar formation as well. This is good for kidney as well. When you have kidney failure, you have too much of scar.
Do we know, Dr. Halasa, do we know if it increases IL-10 or TGF-beta?
Yes, it does, because it increases the Treg effect. So, well,
Interesting.
especially
So,
Treg.
yeah, because you know, when we do allergen immunotherapy and we give it to people, we try to stimulate the Tregs and the B cells to produce IL-10 and TGF-beta. And that's how it works. So then they can prevent the allergic reaction over time. So
Right.
if we do the thymosin beta and it's stimulating the Tregs to produce the TGF-beta and IL-10,
Yeah.
that would be
Yes.
huge for allergists to use.
Yes, it does help
What you
in
are saying is
not
TGF,
in allergy, not in allergy.
TGF-beta, it helps the allergy or it makes it worse?
No, TGF-alpha, TGF-beta actually is the one. So when we give allergen immunotherapy, the way it works is stimulate the Tregs to produce IL-10 and TGF-beta. So that is how that works.
Okay,
No, but
then why in our mold cases, they have a very high TGF-beta, okay? TGF-beta 1 is in thousands. They are like, today I saw a patient who had a 29,000. They are very allergic. And so according to what you say, if TGF-beta is high, Tregs is upregulated, then they should not have allergic response.
Yeah. So normally if the Tregs are upregulated, the people should not have. So IgG subclass 4, when we give allergen immunotherapy, the IgG subclass 4 goes up. But also you have the other cytokines, IL-10 and TGF-beta that go up. And according to allergy literature, those are meant to go and block the IgE, so then that the mediators are not released. And that
I
way,
agree with that. I agree
yes.
with that. But TGF-beta 1, there may be a hermetic response then, because
Right.
if you say that if you give the allergic immunotherapy, we all and that's what I'm doing. We are
Right.
building up the tolerance. Intolerance may be coming from Treg partially.
correct.
And
Yes, correct.
then they have a high TGF-beta 1 because of that.
Right.
Right, but in our mold sensitive patient and mold toxic patients, we see very high, very, very high TGF-beta, and they are highly sensitive patients.
But maybe the sensitivity comes from something else, like toxins and affecting
Let me
the
make sure
muscles and
that
basophils.
we wait a minute. Transforming growth factor beta is a sword with two edges. It's
Yes.
not all the time it's high, it's good. Especially if you have high transforming growth factor beta and interleukin 6, that's not good. That's scar tissue and inflammation. And that's not something you want. In fact, you want to inhibit the transforming growth factor to reduce the scar tissue and inflammation. And so, but in a low dose, especially with interleukin 10, it's good. It stimulates the Tregs, and that's something you wanted. So it's really based on the ratio of interleukin 6 and interleukin 10 that determine the transforming growth factor beta is good or bad. And when it's high.
Yeah, that's the point I was making, that it is
Right.
hermetic reprong. It's a high, it's a low level maybe more protective, and a high level maybe more dangerous.
Yes, especially when
And-
it comes with interleukin 6 and
and-
transforming growth factors both high.
Yeah,
That's
yeah,
not
if they're inflamed, then they're IL-6. But I'm measuring IL-6 and they're not very high. In
I'm
this
also
patient,
doubting the lab too, you know.
yeah,
Those labs
IL-6,
also.
IL-4, IL-10, IL-12,
Yeah.
because I want to see, after doing in number of patients, where do they stand, and they don't follow the pattern. They are just all over.
Sometimes I put question mark in the lab. That's why I will use two labs to make sure they know what they're doing. And the problem with cytokine profile lymphocyte mapping is only one company is doing it. So we really need to have more companies to compete and validate each other. That's, I think, the direction that we're going to move to. But let me go ahead back to thymosin beta. It does stimulate the whole lymphocytes proliferation, so it's good for the whole lymphocyte, but it favors the Th2 and it inhibits the Th1 most of the time. And I don't want to recommend thymosin beta for patient with cancer, or patient with COVID, or patient with and if I do it, I will do it with thymosin alpha along with it. The reason, because it does damp the Th1. So it's good for autoimmune diseases, for systemic lupus or erythematosus, and it also inhibits the Th17. So that's a good thing too for autoimmune diseases. But it favors the Th2, so that's mean you don't use it for allergies, right? Because it may aggravate your allergic reactions.
Well, it depends. I mean, if it's affecting the T regulatory cells, and according to immunology, the Tregs participate in
Yes,
immune
it
tolerance.
does help the Tregs, but at the same time, it may lead to polarization to Th2, and I will use thymosin alpha for allergy versus thymosin beta. Yes, it does. It's good that it increases regulatory T cells. That's right. So that's good for autoimmune disease like systemic lupus, like rheumatoid arthritis, multiple sclerosis. I would use thymosin beta, and also it has, as I said, as we see learner, it may have some stimulation of mTOR. It helps the growth blood vessels and the vascular growth blood vessels, or angiogenesis. So angiogenesis. So I think it's a good thing for healing tissues as well. So for diabetes, I will use it. Diabetic ulcers. I will use it for autoimmune diseases. That's Th1, Th17 dominance, like rheumatoid arthritis and Crohn's disease. But I will not use it for patients with.
Are you still there, Dr. Halasa?
I think he dropped off.
Okay. We'll just give him a couple minutes here.
So what do you guys think about the thymosin beta's effects compared to alpha in terms of stimulating allergy or allergic response? Anybody?
You mean as far as stimulating or helping allergy?
Helping, in terms of helping, because I really think if it has...
Thymosin alpha for sure helps with allergies. And I think it's clear to be cautious with thymosin beta for allergies simply because that's a Th2 mediated condition. But I can say from experience that thymosin alpha helps allergies and asthma.
Okay. So has anybody specifically given thymosin beta to patients with allergic reactions?
With like a drug reaction or?
Yeah, drug reactions or any asthma or any bad allergies, allergic rhinitis or any of those.
I may have given thymosin beta inadvertently with a patient with allergies and everything was okay, but nothing bad happened. But again, sometimes it's not so straightforward because patients will have Th1 and like Th1 mediated autoimmune disease and allergies at the same time. So it's not so clear cut, but my understanding, and I guess I've avoided giving thymosin beta specifically for allergies. I personally would not treat somebody who's having a drug reaction or any kind of allergic reaction with thymosin beta. I would definitely treat them with thymosin alpha if I mean, obviously I would do the antihistamines as well, but thymosin alpha I've seen work really well for allergies, especially asthma.
Okay.
But I think, yeah, I've given I recall giving a patient with asthma, treating them with thymosin beta, and I remember at the time being concerned about the asthma, but fortunately the asthma did not, it was not affected.
So
But
that's a test right there. Even though you did do it without paying attention, it didn't really exacerbate the asthma.
yeah, and that's the beautiful thing about peptide therapy in general, is it's not like the synthetic big pharma drugs that are really pushing those buttons like like slamming on the brakes. Like, if you're driving a car, I feel like big pharma drugs are like slamming on the brakes or the accelerator, whereas peptides being much more gentle modulators, they don't seem to have that same risk. There's a lot of wiggle room with peptides because they are natural. They're working with the physiology, so the body can maybe perhaps regulate them, even if they're theoretically are moving things in the opposite direction. They're not. The body may be able to compensate for that, because I have not had situations where I gave the wrong peptide and I had this terrible adverse reaction. I haven't had that happen with peptides.
It's never happened. I've never seen that happen. I've given all these peptides so often. We've never had something like you see in big pharma where they have an adverse reaction. It doesn't happen.
Exactly, and it's because they're not slamming on the brakes. They're driving appropriately. As you drive, you're tapping the accelerator appropriately. You're not putting the metal to the pedal or whatever, like the big pharma drugs.
So it would be nice to see the combination thymosin alpha 1 and the beta to see how that can modulate immune response. I think I'm really interested in this. I want to know more about that. I'm not really familiar with it.
And I did it that in the beginning, okay?
Yes.
Because I like some of the things that Th1 was doing, some things what Th2 was doing.
Right.
But at the bottom line, some patients, those who had allergies, did not benefit much. But when you give Th1 alone, then you can see absolute benefits. So why to increase the expense of giving two things more together? Instead, just give one thing and see the better response. Many of these patients, those who have the allergies, in my practice, they have a low leukocyte count. And giving TA1, and then it has that acceleration of the making cytokines, interferon gamma, it increases. And that also helps to increase the white cell count. And so I have found that that helps a lymphocyte count particularly. So, and phagocytic activity. So I've been using that more. If I want to increase the white cell count and a lymphocyte, then it may be a good idea to give very small amount of the granulocyte stimulating factor and very small amount of TA1, which will help to also accelerate the phenotyping of lymphocyte. So there are ways that you can modulate the system, but you have to be careful. I mean, if you give TH2 and if patient doesn't get better, then you know that that's not the molecule to use. But I have
Right.
used TH1 and TH2 together when somebody has a super acute infection. You want to control the infection, and at the same time, you want to induce the anti-inflammatory effect of calming the rest of the leftover inflammation, like reduce that.
Yeah,
So,
because I see a lot of patients with mast cell activation syndrome,
right.
and those patients are really sick. So I'm trying to figure out.
Do you use thymosin alpha for the mast cell activation syndrome? Don't use the thymosin beta. You favor it because the histamines activated, mainly they are moving to TH2 and TH17, and I think the best drug for that is thymosin alpha. Now, so you can shift them away. So, but thymosin beta, I will give it for Parkinson disease. I will give it for Crohn's disease. I'll give it for multiple sclerosis. Yes, and I with peace of mind because I know exactly what I'm expecting from giving it. But as Dr. Patel said, if you just want to increase the immune system regarding of where direction it is, then you can give them both together and you just balance the whole thing, and there's no any favor from either side is being canceled from each other, and you just boost the whole immune system evenly. But very clear here, you can see that it does have inhibited TH1 when it's being excessive, and that's why in rheumatoid arthritis and multiple sclerosis it does boost the TH1, TH2, and sometimes it pushed it to TH2 too much. And allergy, so I will not use thymosin alpha here. And it doesn't have the TH17, which is a good thing for all autoimmune diseases. You know, even allergies, there is activity of TH17. TH17 is active in all autoimmune allergic reactions and cancer.
I do want to just add something really quick to what Dr. Tano said. What I do for mast cell, for the really, really bad mast cell patients, it's the combination of thymosin alpha and then amlexinox, because that's also a mast cell stabilizer. But ketotifen is the strongest mast cell stabilizer that I'm aware of. It's not a peptide, but it's a small molecule, which I like small molecules
Yeah,
because
that I use that a lot too, the ketotifen.
yeah. So the combination, I've used amlexinox along with the ketotifen and then even thymosin alpha for the severe, the most of, I'm talking about the people that any little thing sets them
Yeah.
off. They can't
Right.
even eat. They can't even eat hardly
Correct.
anything. And then I'm also giving them the BPC 157 and KPV in capsule form, all at the same time.
Okay. Yeah, I
So
have such a
the
patient
point
right
is,
now. I need to cure. I don't know.
I want to make sure that you know every peptide has a hormetic curve. So you will find some patients really being sensitized by your peptide, like you just mentioned about KPV. My patient had a super mast cell activation, and she was cruising. So and she had little bit of more uh, inflammation. So I thought maybe I can give her KPV. And she was able to eat 2 foods. When I did her allergy testing and everything, I brought her back to eating 36 food. Okay. And then, I mean, she said, Dr. Patel, can you do it? And she was on TA1, but then I added KPV, and she became so sensitized, and she had like anaphylactic shock type of reaction, and she went back to 2 foods. And
Wait,
then
wait, wait. What do you mean she got sensitized? Wait, I thought the KPV was helping her, and then
no,
what?
no, it did not. The minute I started her on KPV on day 2, on day 1, she had almost like anaphylactic reaction.
Well, I mean, like I said, I start with ketotifen, and then I add the other things.
This is the patient who was extremely chemically sensitive. She had a
Right.
COVID vaccine, and
Right.
she immediately collapsed, and she had anaphylactic shock, and she was hospitalized for 2-3 weeks.
Well,
And then when she came out of the hospital, she was able to eat only 2 food.
okay, so basically, that's kind of like what I was talking about before, is the smaller percentage of patients that are so sensitive that anything, literally anything
And
can.
TA1, she didn't have a problem, okay? TA1, she didn't have a problem.
Because
But I'm just-
Tier one is polarizing immune system to TH1 inhibiting the TH2, so we
and
can see it's part of the management for sensitivity.
That makes sense, because remember when I said there's for those sensitive, very sensitive, remember I said earlier, I start with the thymosin alpha before even giving BPC 157 KPV. Remember I said that earlier.
you did mention, but I want to emphasize again.
Okay.
You mentioned that they can have reactions. So I'm just exemplifying these.
No, exactly. No, actually, I'm glad you brought that up, because I mean, especially because you're dealing with it, you're the expert on this, by far. And, I'm glad you brought that up, because
Let me add something which is very
it
important here.
verifies, even more, or makes me more confident about that approach, that starting with the thymosin alpha.
Right. Let me add something very important here. When I was doing research with Dr. Frank Arson in Baylor College, he was specialized in moving or shifting or managing allergies, Pennett's allergies. So he takes the genetics from the DNA from the bacteria, which is the plasmids expressing the Pennett's allergens, and then he injects them into the skin, and then those dendritic cells will take them. And when they take them, instead of polarizing the immune system to TH2, they polarize the immune system to TH1. So the whole idea is that he's desensitizing the body by shifting the immune system from TH2 to TH7 to TH1 as a treatment for allergy, as a permanent treatment for allergy for Pennett's. And in general, if we want to treat patients with allergy, especially with eczema and all that stuff, you need to give them things that polarize the immune system to TH1. And thymosin alpha, it's a good drug that you can give that even permanent, not like antihistamine and those cortisone, which is temporary suppression. This is more of training the immune system to become tolerant to whatever trigger the allergic reactions
So
by
this means
training
this
it to
means
TH1.
this means that that Dupixent, Regeneron has a Dupixent. It's like their miracle medicine they call for the allergic asthma, eosinophilic asthma, eczema, and etc. So I think that we don't know whether that one is doing the TH1 polarization, but my patient who was on TH1, TA1, but she was super asthmatic, so she had a periodic use of steroids. And then I said, why don't you try Dupixent and go to the person that who was giving Dupixent, and her asthma improved tremendously. So I think that we should know that no matter what we give, but there are some limitations, and there are some newer antibody treatment that may be of a help. And we don't know. We have not done any work on immunotyping on these patients, that would really help before the treatment and after the treatment and what happens to them.
But
Do we
talking
actually
generally
have
speaking, I'm talking about generally speaking, the way that we treat allergy, asthma, and all this allergic reaction is to shift the immune system from Th2 to Th1. That's well known. Even the skin desensitization that we are doing is actually polarizing the immune system from Th2 to Th1, because when you introduce in the skin, the dendritic cells will take them and present them to the lymphocytes, and that favor the polarization into Th1. So that's how the desensitization mechanism work when we do injection subcutaneously to desensitize the body from those allergens. It works by polarizing immune system Th1.
So
I
then
believe
we
the
do
same
have
drug.
we do have some non-genomic pathways through which people get allergic reactions. For instance, when you have estrogen overload, but don't go through the IgE-mediated reaction or IgG-mediated reaction, because they have receptors on the mast cells and basophils. So are many of the toxins, environmental toxins, by the way. So if they have those, how do you approach it? If you give them this, the thymosin alpha, it may not work because it's not polarizing the T cells in a way. So my question is, are there any other ways of, say, blocking the toxins such as xenoestrogens with peptides?
So there's two parts of what you talked about.
Yes.
You talk about principally, this is the principle, that we need to train the immune system to move to Th1 to manage allergies. And any histamine overreaction is both, it's Th2 and Th17. So
Not
doing
always,
that is
though.
part of
Yes.
the management. But if you say, well, we need to get rid from the root cause as well, which is the triggers.
Right. Yes.
Yes, I will agree with that. You need to detox the body and remove those allergens source from the beginning. That will be part of the management, but does not negate the general principle of training of polarizing immune system Th1 as part of the treatment of allergic reactions, detoxing, and avoiding exposure to the toxins, other gene. It's part of the management, yes.
Do we have anything for xenoestrogen? Does anybody know if we have
It's
any
very difficult
peptides?
to get rid from the fat-soluble toxins. But again, the things that helps to clear the liver. There's something that Dr. Joseph is entertaining, sweating, sauna, and weight loss along with sauna to sweat the sweat itself can take the fat tissue out, but you need to wash at the same time with soap when you're doing the sauna, so you can get rid from all this fat soluble toxins that's being secreted from the sweat with sauna thing. But as a detox agent that causes chelation of fat toxins, it's very difficult to find. I mean, you can use a zeolite activated charcoal, but mainly they get rid from the water soluble toxins versus the fat. The only thing I can see is weight loss and sauna. That may be the reasonable, plus washing and cleaning after you do the sauna, because it will not those toxins will not be reabsorbed. It makes sense?
Yeah.
Okay.
Well, yeah, and I think we should another lecture we should do then is some of these detoxing strategies, and even the dietary approaches, finding evidence with different smoothie combinations that have natural chelators, and maybe even looking for evidence with celery juice by itself, things like that. I mean, you saw what my transformation just from doing those two things. You saw my weight changed, and obviously my liver congestion has shrunk. There's a lot I think we could really get into. We always say detoxing, but we don't get specific to exactly what we can do or how we should approach it specifically. And I think that's something I'd like to get into as well in lecture.
Actually, I agree with you 100%, Dr. Joseph. I think tomorrow's medicine, if you ask me, will be detox medicine, because we're not getting rid of the toxins. So the sooner we find out a way to detoxify the body, the better off we're all going to be. So if we have strategies through this group, learning how to effectively detoxify individuals, we're going to get probably better results.
Right.
I
Okay,
agree.
so can we do these 3 slides and then we can have,
Yes,
because
yes.
the time for the CME is 2 hours. So we just get these 2 slides and then we discontinue. In other words, we can close the recording and then we can talk. But just let's get these 3 slides of thymosin beta. I'm not going to talk about the GLP-1. Clinical application of thymosin beta has been explored in animal experiments and clinical trials for various indications. And because it has a healing effect, stimulating the mTOR and has a vascular and decrease the vascular, angiogenesis, I think it's good for myocardial infarction. As well, this inflammation that's mediated in myocardial infarction is Th17 and Th1. I think inhibiting them with thymosin beta is a good thing. I think it's good for liver and renal fibrosis because it stimulates the Tregs and it have the Th17. So I think it's a good thing to have that. And it's good for xerophthalmia because most of the xerophthalmia is Th1 dominant autoimmune diseases. So having the thymosin beta to inhibit the Th1 and move and stimulate the Tregs and having Th17 as well, it's a good thing. And it has the mitotic effect. In other words, it mTOR stimulate the mTOR. It's a good thing. It's good for ulcerative colitis and colon cancer. I will say it's good for yes, ulcerative colitis. But also colitis, it's more of Th2 dominancy. Some cases. This is a little bit. I will go with Crohn's disease better. Some ulcerative colitis Th2 dominant, so Crohn's disease will be good. Some of the colon cancer, as I said, it may have some good in metastasis, but I will not use it for cancer, thymosin beta, by the way, in general. Skin trauma, yes, for its healing effect. It's also used for immune support, especially in conjunction with thymosin alpha. Yeah, if you recycle it or you want to just to boost the immune system without regarding of the favor. But I will not use it for cancer because there is some, it may suppress the Th1 and we don't want that. In general, dosage, the general recommended dose for thymosin beta is 300 microgram to 1 gram daily, administered subcutaneously, and adjusted doses based on clinical presentation. Less for immune support, more tissue repair, and for a combination of both. Avoid continuous dosing of more than 3 months and consider recycling 3 to 6 months. That will be indication for any investigating drugs. The most side effects is injection site pain and redness, which should be demonstrated over time. Some individual may experience fatigue or headache, which usually resolve quickly. Delayed wound healing in diabetic patients. So it's a good thing for diabetic because it does stimulate the mTOR and the blood vessel regeneration and decrease the inflammation, especially inhibiting the Th17. So a 60 years old diabetic patient with non-healing foot ulcer despite standard wound care, the wound remained stagnant. Treatment, the patients receive subcutaneous TB4 injection, 300 microgram daily, maybe around the injury or around the wound. TB4 enhanced angiogenesis, promote tissue repair, and reduce the inflammation. The outcome, the wound gradually close and the patient experience improvement healing. Autoimmune disorder, especially with the one with Th17 dominance, and also Th1. Example is a patient with autoimmune disease characterized by joint pain and skin rash and Th17 cells is overactive. Treatment, thymosin beta 4 administered 500 microgram daily to modulate Th17 because it doesn't have the Th17. And if there's any cancer effect, maybe because it's inhibition of Th17. But I will not use thymosin. If I have thymosin alpha, I will use thymosin alpha over thymosin beta to manage cancer. Over several months, the patient's symptoms improve and interleukin-7 decreases. The outcome, reduced inflammation, better joint mobility, for sure. Rheumatoid arthritis is good. For osteoarthritis is good. post-cardiac surgery and recovery, yes, because it inhibits the TH17, it improves the angiogenesis, the angiogenesis, it stimulates the healing, it stimulates the mTOR. I would definitely use it for a 50-year-old man undergo coronary artery bypass graft surgery. He's recovered. It's complicated by slow wound healing and fatigue, and treatment is thymosin beta 4, 1 gram per day is given post-operatively to accelerate the tissue repair, support cardiac function, and reduce inflammation. And the outcome was improved wound healing and faster recovery and enhanced overall well-being. The question here: what is the primary rule of thymosin beta 4 in wound healing? Does it inhibit angiogenesis? No, it stimulates. Promote tissue regeneration? Yes. It decreases the vascular endothelium? Wrong. Increase the scar formation is wrong. So promoting tissue regeneration. Which T cell subset is down regulated by thymosin beta to reduce the autoimmune inflammation? We know it's TH17, right? Mainly. I mean, there's some TH1, but mainly it's TH17, so I'll go with TH17. Thymosin beta has been shown to enhance the function of which of the following of the immune tolerance? Okay, so which one we're going to see here? I think it will stimulate the Tregs, and that's true. What is the common recommended dosage range for thymosin beta? We talked about it. It's around 300 microgram to 1 gram daily. Which of the following is potential side effects of thymosin beta therapy? Injection site pain and redness. I think that's what we have. Okay, I think we're good.
Yeah, right. Oh, go back to the questions, please.
Yes, here.
Yeah, look at the question there, 3. The role of the thymosin beta, it says it helps stimulate the T regulatory cell, therefore it intervenes in the immune tolerance. That's what I'm saying. So
yes, but the problem with, yes, you're right. But the problem also, see, this is the problem with, it's not just one way. It also polarizes the immune system to TH2. And just my advice, if you have allergy, don't give them thymosin beta, give them thymosin alpha, because thymosin alpha doesn't have the TH17, and yes, it will increase the Treg, but it moves things into TH1. So I will rather give thymosin alpha for this patient. You got my point?
Yeah.
I don't want you to give a patient thymosin beta for allergy and you end up with aggravating the allergy in general.
So what other combinations? So we're done with the lecture, right?
Yes, let me go ahead and so we can, I think we're done with the CME now. Are you there, Dr. Shill? Shill, are you there?
Yes, I'm here. Should we start the recording?
Yeah, can you stop the recording, please?
Okay.
Because I'm relying on your recording because I